Hello guys and welcome back to my channel. My name is Tommy. I'm a human nutrition student and researcher at the university. What I do here is to synthesize the classes I have at the university, and then I explain and teach you here the best and most valuable information you need to know of each and every one of my subjects. Today we're going to start a new series of videos in which we're going to talk about dietotherapy. So how the diet of the individual that's in therapy changes before, during and after the therapy. So let's begin. Dietotherapy is created because in hospitals there is malnutrition, and malnutrition will lead to death indeed. We have already seen that in all the videos. So the nutritional attention increases. The definition of the dietotherapy is nutritional guidelines or restrictions to improve or cure diseases, mainly to improve them. Who is in charge of this dietotherapy? Dietists or nutritionists? Well, the dietist knows about diets, and there is no university degree here. Nutritionists, though, they know about nutrients and pathologies. This is the key, and it requires a university degree, which is what I'm doing. The dietetic treatment has some requisites. The first one is to cure or improve the health therapy, according to the definition. The second one is to correct the nutritional contribution, and the third one, it has to do with patient's taste. You cannot recommend a diet to a patient if he or she will not like the food in the diet. So there are some codes for different diets, and these are classified by many authors, but basically they are the following. Classification by groups of diets. We have the basal one, which is created for age and culture. So basically the one that everyone needs a proper diet for their age. It's not the same giving the diet to children or to pregnant women or to the elderly. And culture. For example, I am Italian, and my culinary culture is very different than the one, for example, in India or in the US or in the United Kingdom. Then there are the modified diets. Modified texture, solid, semi-solid, semi-liquid or liquid, energy modification, carbohydrates modification, fats modification, minerals modification. These are all set to adapt to different circumstances of diseases. Then there are also diets for allergy or intolerance, and also diets for expiatory purposes. Another classification is this one, therapeutic diets. It can be essential or curative, adjuvant or palliative, preventive, facilitating, exploratory, for example, the colonoscopy, and artificial diets. Another classification is qualitative, which changes the texture, quantitative, which changes the calories and macros, the therapeutic complete and the therapeutic incomplete, as well as the progressive diet. Progressive diet is going from, for example, artificial nutrition to a liquid incomplete, to a liquid complete, then to a semi-solid, then to a bland, which is facilitating chewing, basal facilitating chewing, and basal. Of course, these last two are solid. Then we need to take a look at dietetic interactions. So you have to know that patients are often polymedicated. So we need to see which interactions happen between the medication they're taking and the food they're eating. High consumption of drugs, high interactions. So basically the dietetic interactions are the effects, food, drug, and vice versa. They occur because the drugs are tested in a fasted state, so we cannot really know what are the consequences when mixing them with food. Classification, nutrient to drug, so nutrients affecting the drug, pharmacokinetics and pharmacodynamics. Pharmacokinetics talk about the bioavailability of the drug, how the nutrient, the food, affects the bioavailability. Absorption, distribution, metabolism, excretion. In absorption, the drugs taken with or without food. There is a physical barrier, pH, insoluble compounds, gastric emptying, and intestinal mobility. They are all factors that affect the absorption. The distribution, higher proteins and higher fats, will lower the distribution. Metabolism, the cytochrome P450 affects the drug effectiveness, and the nutrients can block the cytochrome P450. Therefore, the drug effect will become even higher. And excretion, if it's not ionized, it may change the urine pH and reabsorb which is something no bueno. Here I put ionized and not ionized because these are the proper ways of absorbing the drug, not ionized form, and excreting the drug, ionized form. Pharmacokinetics have to do with the potency of the drug, so the effect on the body, and there is an interaction between vitamin K and anticoagulants. Then there is also the drug-nutrient interaction, so how drugs interact with nutrients, and the effects are, for example, anti-nutrient effect, laxative, organoleptic changes, psychotropics, antidepressants, hypogeusia, dysgeusia, high urinary excretion of vitamins and minerals, catabolic stress, lower appetite, lower intakes, malabsorption and metabolism changes. The examples are psychotropics will increase the appetite and amphetamines will lower the appetite. Clinical interactions, well, with oral antineuroplastics, there is interactions with food and medicinal plants. Antiretroviral, there is an alteration of the cytochrome P450, which is the one in charge of the metabolism. Immunosuppressants, they create interactions with food. There are also interactions with alcohol, so nutrient drug, the alcohol with the drugs. Pharmacokinetics types, so affecting the absorption, distribution, metabolism, and excretion. With alcohol, there is higher absorption, which can be dangerous, and this is due because there is more time to empty the stomach, so higher time in contact and therefore higher absorption. Higher distribution, it easily gets in the central nervous system. Lower metabolism, cytochrome P450 inhibition, so this will metabolize the drug in lower quantities and therefore increase the effect of it. Higher excretion though, no antidiuretic hormone, but chronically this will decrease, so there is a liquid retention. At the pharmacodynamic level, well, it is hypoglycemic, hemorrhagic and sedative, and the other way around, so drugs affecting alcohol, for example, the disulfiram will create nasal congestion, sweating, nausea, vomiting, blurry vision, dyspnea, hyperventilation, tachycardia, hypertension, confusion, etc. So there is a clear indication of higher interactions. And the same thing is applied to enteral nutrition. If you want to know more about these interactions between the medication, the drugs, and the food, I have a series of videos in my channel called Pharmacology, in which I explain this in much more detail. You can find the videos here. So now let's take a look at the dietotherapy process. There's this thing called the nutritional care process. It's a protocol which uses critical thinking. It has a structure, documentation, and scientific evidence. It is based on the Hammond model from the 1970, and it has been updated in 2002. So the phases of this protocol are the following. The first one is to assess. It is similar to an anamnesis. Is there a nutritional problem? How and what he or she eats? So anthropometry, physical activity, nutritional assessment. We gather the information here. Then the diagnose. We identify the problem. What is it? The causes? How do we know it? And there is this thing called the PES, which is not pro-evolution soccer, but problem, etiology, signs and symptoms. Indeed, signs and symptoms, we can refer them as syndrome. So to remember it, problems, etiology, syndrome, signs and symptoms. This is used to standardize the diagnosis. Number 3 is to intervene, assign goals and a detailed prescription, explain the reasons behind the guidelines, make realistic changes tailored to the individual. You cannot tell people with obesity to just don't eat anything or drop the calories so much just because this is the protocol. You have to adapt it to the individual. Therefore, we have heterogeneous versus homogeneous groups and the quantitative and qualitative diets. I have a video here in my channel called Dietetic's Diet Creation, in which I explain this in more detail. The fourth step is to evaluate. So we have to check if everything is going as expected. We have to get a feedback and also self-criticism. This is to readjust the diet. And we also have to give them food and nutrition education. So the composition of the food and also education on a healthy way of eating, healthy combinations of food, and a healthy relationship with food. Therefore, after doing this evaluation, we can go back to the assess and this is a cycle that can repeat because we always have to get feedback, self-criticism, and readjust. Okay, so that's it for this video. I hope you understood everything I said. If you didn't, there is a comment section down below. Remember to download this diagram by clicking in the first link in the description down below. Like this video, subscribe to the channel, turn on the notifications to get notified every time I upload a new video. Share this video to your friends and family to spread this knowledge to them as well. Thank you so much for watching, and I will see you in the next one. Ciao! Hope you enjoyed.